I want to welcome you this morning and thank you for bearing with the weather today and coming to join us this morning. And we do hope you'll find this enjoyable and informative, and that you'll leave with your questions addressed. So the format will be this. I'm going to give a brief overview of atrial fibrillation, largely to have some concepts that we'll further explore in the morning, and also go through some terminology that we'll be talking about. So we'll be on the same page together. Then I have this expert panel who I'll be introducing in just a moment, and we'll do kind of like a Dr. Phil show. I mean, we'll have a little interchange in terms of, different, getting our expert opinions on things. And then finally, we'll have a question and answer session where it will be opened up to you. Each of you has a pad and a pen, I hope, and you'll be encouraged to write questions down. We'll collect them at the time of question and answer, and we'll try to get through as many as we can in our question and answer time. We're really fortunate to have this videotaped. So I'm told February 19th, this will be up on the website. The website is listed out front, but is stanfordhospital.org/arrhythmia. And so you won't need to take notes. So if there's anything you want to refer to, it'll be available as part of the video. So we're really grateful for that ability. Okay, so I'd like to just go ahead and go through our initial introduction. So first, this is a list of our faculty. So myself as director of the service, Dr. Zai, Dr. Friday, Dr. Tarakia, Dr. Perez, Dr. Park, and Dr. Viswanathan. And these are our panels. So I'll ask them to wave to you, and then they'll, of course, speak later. So Dr. Park, do you want to? Yes? Okay. Dr. Beghi is one of our senior cardiothoracic surgeons. That's why he's not listed on the first slide, but we're so grateful for his expertise and his involvement in arrhythmia care. Angela Sipperfall is a nurse practitioner, and Linda Norton is our research manager, and Sophia Liu works with Dr. Beghi. So we have really an expert group of people here today. Okay, great. So this is our mission statement. Every group should have a mission statement, and ours is that we're dedicated to delivering outstanding and compassionate care to our patients while working with their physicians and advancing teaching and medical research in arrhythmias. And we really pledge to you and all of our patients and your physicians that we place very seriously the trust that we have. Our vision also is really to attain and maintain ourselves as one of the top programs in the country, advancing as a leader in innovation and translational research and providing outstanding service and access. So we'll be talking about atrial fibrillation. We all are involved in a wide range of different treatments and procedures as well. But as you know, this morning's session is focused on atrial fibrillation. So first, some of the things I'd like to talk about are really how the patient experiences atrial fibrillation and what is that like. So it is very varied. We're very individual as how we experience different conditions, and that's really true for atrial fibrillation. So one might have as the main symptom that of palpitations, which you might describe as a jumping sensation, a racing heart sensation, or sometimes just an irregularity, a pause followed by a strong beat, etc. It also can have more dramatic symptoms, such as dizziness, loss of consciousness even, and this sense of rapid tachycardia. What are some of the other associated symptoms that we can consider? So it might be symptoms like shortness of breath, chest pain, and syncope as loss of consciousness. A frequent question that we're often asked is, what are some of the things that precipitate atrial fibrillation? In my experience, this is really individual. That is, for one person, this might be a precipitating factor. For others, it really doesn't have the same importance. But it might be something as general as exhaustion, fatigue, working too hard, those kinds of things. Volume depletion, becoming dehydrated, you haven't had the proper amount of food or drink. Stimulants, caffeine, alcohol, for some people, not all, can serve a role as a precipitant. Sleep abnormalities, whether it be a true sleep apnea condition or just lacking sleep, being exhausted because you are off in their sleep cycle or missing sleep. And then physical and emotional stress. For some people is quite a dramatic stimulant or in fact precipitating factor for atrial fibrillation. So as we'll talk about further, how do we describe atrial fibrillation to our patients? And so there are a variety of ways to do that. This is a little diagram to give you something visual for what atrial fibrillation might look like. And we describe it as a swirling around like a windstorm or sandstorm within the upper chambers, the atria. And so that's a general kind of picture you might have in your mind about what atrial fibrillation is. So just a word about the magnitude. And so we know that several million people have atrial fibrillation in the US alone. It's estimated to be 3 million or more and rapidly increasing. And there are a variety of different conditions that are associated with it. That is, one has a several-fold increased risk of having stroke compared to a similar age person without atrial fibrillation. So this picture is designed to give you a sense of what are the demographics of patients with atrial fibrillation. So we see in the dotted line the US population and age. And so you're all very familiar that there's a baby booming phenomenon occurring, right? So there's this population that is moving and getting older as we go to the right of the screen. Then we see in green the distribution of atrial fibrillation. So you see it's generally shifted to the right. That doesn't mean younger patients don't have atrial fibrillation. We saw some, teenagers who had atrial fibrillation recently. So it can be throughout the spectrum, but certainly the majority of people are between 60 and 85 years of age. That's the vast majority of people who have atrial fibrillation, as you can tell from this. Okay. So another term. So you'll sometimes hear people talk about paroxysmal atrial fibrillation. And that refers to atrial fibrillation that stops and starts on its own. It may be a variable duration, minutes to hours, but indeed it stops on its own power. Persistent atrial fibrillation generally requires medications or what we call electrical conversion, we call cardioversion, an electrical shock to the chest to convert the rhythm back to normal. And so that's the difference in terms of the terminology of paroxysmal or persistent atrial fibrillation. So what can we learn about the impact of atrial fibrillation on the body? So the first thing to recognize is atrial fibrillation starts in the upper chambers, and we'll describe, the heart as a two-story building, a top floor and a bottom floor. So it starts in the top floor and then needs to travel to the bottom floor. The lower chambers called the ventricles that pump the blood through the body. So they get there through a staircase. So it goes from the top to the bottom, and that staircase is listed here is called the AV node. So it goes from the top through a staircase down to the bottom. So when we talk about the heart rate, we're talking about the rate in the bottom chamber, the ventricular rate. That's what we're saying when you say, well, my heart is fast. That's what you're referring to. Because in atrial fibrillation, we know the top chambers are always fast, but then we want to ask further, how fast is the bottom chamber? So one of our first principles of treatment is really to control the rate. How many impulses get from the top to the bottom to the chamber? And why is that important? Because simply controlling the rate for many patients can in fact make them feel much better. It really kind of calms the heart, calms the body, and makes them feel much more at ease rather than really often very uncomfortable. And so we have our standard medications. So there are medications that are readily available that have been used for decades that are very effective in general in terms of controlling rates. So digoxin, which is a very old medicine, beta blockers called metoprolol, atenolol, propranolol, a number of agents are available, and calcium channel blockers such as diltiazem or verapamil. So these are agents that are really quite effective in controlling the heart rate, how many beats get from the top to the bottom chamber. Okay. So then the next thing we'll talk about is the ability to keep the rhythm in normal rhythm. We call normal rhythm sinus rhythm because that's the mechanism we talk about. And so for patients that remain symptomatic despite having good rate control, which you've achieved using the medications we just talked about, we may want to pick one of these agents that we call antiarrhythmic agents. Okay? So we'll talk a little bit about what are the different factors that allow us to choose among these agents. So there are 6 such agents that are available in groups, each of 2, flecainide or propafenone, sotalol or dofetilide, or amiodarone or dronedarone. So these 6 agents are the agents we call the antiarrhythmic agents or drugs. And then we'll be talking about how the presence of coronary artery disease, pumping dysfunction, other factors might be used to select and individualize for that patient which might be the most suitable to start with. Okay. The next big issue and the topic on the top is really correct. We really want to prevent stroke. Because there is an association with risk of stroke, we really want to do the best we can in terms of reducing the risk of stroke in patients with atrial fibrillation. And we'll talk more about these risk factors and what are the different agents that can be used in the subsequent slides. So this is a slide that kind of summarizes the ability of anticoagulation, of which the oldest agent is called warfarin or Coumadin, to reduce the risk of stroke. And that's true across ages and across having or having not any of the risk factors for stroke. So pretty uniformly across the spectrum, it's able to reduce the risk of stroke to quite a low risk compared to the risk otherwise being off anticoagulants. One of the questions we're then asked is, can we use a scoring system to estimate one's risk and therefore the need for anticoagulation? So this is called the CHADS-2. You can see the capital CHADS, and there's a subscript 2 score. So this is the most commonly used score in the US today. And I'll talk about another score in just a moment on the next slide. And so you can see on the right what the scoring means. So they really mean score. They mean little points that are counted. So you get 1 point for CHF, which is congestive heart failure, 1 point for HTN, which is hypertension, high blood pressure, another point for age 75 or greater years, and the presence of diabetes. For stroke or transient ischemic events, you get 2 points. So when you add those up, you can obviously start from 0, or you could have quite a few number of points. You can look at the table here and decide what might be indicated by current guidelines. These guidelines have been available for a decade or more. So you might say aspirin alone if your score is low. Intermediate score of 1 would be aspirin or warfarin, and we'll talk about the other anticoagulants in a moment. Or 2 or higher, really anticoagulation is generally indicated. So obviously this is very general. This is what the guidelines indicate, but we would want to individualize for each patient as to what makes most sense based on risk benefit. I did mention there's a new score, and so this is in fact called the CHADS-2-VASC score, which stands for vascular. And so it's been adopted, and we've highlighted what the differences are. You can see that some of them are the same. Congestive heart failure, hypertension, diabetes, or stroke are the same. But for age 75, there are 2 points given. For age 65 to 74, there's 1 point given. Vascular disease of different kinds, and female, 1 point. So you can see it's a little different in terms of the scoring, and yet the implications for selecting the agents are the same. So 0 is aspirin, 0 or 1 is aspirin or warfarin, and 1 point, and then 2 and above would be warfarin or another anticoagulant. So the same treatment is used, but a scoring points system which is a little higher than the one of CHADS-2. So this is an evolution. This has been adopted by the European societies. The current US societies are still looking at this and going to rule soon. So we may be moving towards this somewhat more aggressive scale. Okay, so I mentioned about anticoagulation. So warfarin, as I mentioned, is in fact used very commonly. It's been around for decades. One thing I did want to mention is that there are now approved, and by many insurance companies, including Medicare, home INR monitoring. So if you're on chronic anticoagulation, you can get a home kit, which many of my patients like because it allows them to travel, et cetera, and be a little freer from a laboratory. The newer agents have the benefit that they do not require regular blood checks. They also do not have the same food or drug interactions as warfarin or Coumadin does. And so the three agents that are available are dabigatran or Pradaxa, rivaroxaban or Xarelto, and apixaban or Eliquis. Again, with those major advantages overall. Okay. So next we'll talk about other treatment modalities. And one of the things that very commonly comes up with our conversation with our patients is the treatment choice called catheter ablation. So what is catheter ablation? What are we referring to? So catheters are plastic tubes that we insert into the body to the heart. Ablation refers to killing islands of cells that are used to treat the heart rhythm problem. And catheter ablation is therefore using these catheters to treat these conditions. And generally that's if the patients remain symptomatic despite medications. And so they might be very specific symptoms, or they might be more general, such as shortness of breath or limitations of exertion. So this is a treatment modality typically when medications have not been successful and is an alternative to medicine. So what are some of the general principles that we have used? And this is evolving. As we gain more and more information about atrial fibrillation, indeed, we've learned how to treat these better. The general paradigm, however, is illustrated in this picture. So as I mentioned, atrial fibrillation is a condition which affects the upper chambers, the atria. And in particular, for most patients, the left atrium has a particularly important role. The left atrium serves as a reservoir in which it collects blood from the lungs. And the lungs, in fact, use these tubes called pulmonary veins, and they're illustrated by these kind of funnels or tubes that come into the left atrium. And so these areas, the pulmonary veins, are felt to be triggers. That is, they provide a source of signal that in fact may lead to atrial fibrillation, or most commonly do. So blocking these signals, illustrated by these dots, are what catheter ablation predominantly tries to do. That's a major agreed upon paradigm that in fact by blocking the signals, preventing these little stars from coming out of the pulmonary veins and going to the rest of the atrium is an important strategy to prevent atrial fibrillation. So there are currently 2 approved energy sources. So we mentioned that we need to kill little islands of cells responsible for the condition. So you can do that with various energy sources. They're more in research and development, but approved are both radio waves, called radio frequency, and freezing, called cryoablation. And laser is in clinical trials at present. Okay, great. This is the first multi-centered FDA trial for radiofrequency, which shows the outcomes in that trial, which shows you compared to antiarrhythmic drugs in blue, you can see about 1 year's time, as there's 60% effectiveness preventing any atrial fibrillation recurrence using the radiofrequency energy. This is the cryo or freezing energy, which uses, instead of a single point catheter, a balloon catheter to deliver that energy. This is the result of the first trial, the first generation of balloon catheters, and you see a 70% freedom from atrial fibrillation, with about 19% of people requiring a redo during that. And the second generation has led to even better results than this. In follow-up, for example, in the cryoablation, people look to see whether the pulmonary veins remain treated, and the vast majority, 85% or higher, remained effectively treated. So when we summarize this, we kind of look at the overall risk. The risk of major complications is probably 3 to 5%. The success is probably in the range of 60, 80%, but it may require a second procedure. And the success is lower for what we all describe as persistent atrial fibrillation. That is the need to convert the atrial fibrillation. There is an early incidence of early atrial fibrillation that tends to go away, as well as new atrial arrhythmias and flutters that also tend to resolve. The other predictor of lack of success or decreased success is atrial size. As the atrial size gets larger, the success of a single procedure in particular is less. Okay, so are there newer concepts in atrial fibrillation? So this illustrates one of the, I would say, still investigational or fairly new strategy, and that's to answer the question, are there other key sites in addition to the pulmonary veins that should be approached? And so what people do is obtain these nice color maps to try to determine where there might be other areas that you would want to ablate. And there's some early clinical trials, as they're very early, to kind of show that there might be benefit of using this kind of an approach. So more to come on this topic, in my opinion. Okay. So we've kind of looked at atrial fibrillation as a broad category, but as we've talked about, everybody is individual. And so is there a need, in fact, to tailor what goes on for each patient? And I would argue very strongly yes, because we've talked largely about tools that are really quite effective for patients with paroxysmal atrial fibrillation, many patients with persistent atrial fibrillation. But when we get into this red category, that is patients with very large atria that have persistent atrial fibrillation or have been in atrial fibrillation for many years, those are the patients that are going to be harder and harder to treat. And we'll look at different options for those patients. So one of those options that Dr. Beghi will be talking about in some of the question and answers is a hybrid procedure. And so hybrid, you know about hybrid cars, and so what is a hybrid procedure like? So what we've talked about so far in terms of treatment is called catheter ablation. So as we mentioned, catheters go into the body and basically enter the inside of the heart. So in the hybrid procedure, we're approaching it not only from the inside, but also from the outside. So an outside and inside approach, hence hybrid. And this is done through small ports in the right and left chest that Dr. Beghi will talk about. It does require a longer hospitalization, therefore a longer, more discomfort, but at probably a higher success rate. Okay, this is some early data from Europe and in Virginia, but it gives you an idea that success can be quite high even in patients with persistent atrial fibrillation. Okay, so when we try to answer the question, is catheter ablation better or are medications better? So some of the observations is when we have compared them, catheter ablation generally results in fewer symptoms and fewer total number of atrial fibrillation episodes. However, this question remains unanswered today. That is, which strategy results in the lowest risk of stroke and the lowest risk of death? The Cabana trial is a landmark NIH trial still underway. Several thousand people have been enrolled to date, but compares patients exactly for this purpose, drug versus ablation treatment. So that's something that's undergoing. We're one of 100 centers throughout the world, and in fact, actively recruiting patients for this trial. So it's really designed to answer this fundamental question: is the overall stroke, cardiovascular event rate, and survival greater with each one of these strategies? And we don't know the answer definitively. There are other new things that are on the horizon. This is one catheter that we've been asked to participate in, a new form of radiofrequency energy catheter. It has multi-points as opposed to the current catheters that have one point. So that's something we'll be participating in. And we participated in the first trial of what's called the dual epicardial endocardial persistent atrial fibrillation trial. So epicardial is the outside, endocardial is the inside. So this was the first first trial, multi-center trial for this hybrid procedure. And we expect to start up another trial soon. So to give you some take-home messages before we go into our next phase of our talk, the question and answer on our panel, I would provide these following points. So one is that rate control generally is a cornerstone of treatment of atrial fibrillation. That ability to quiet down the heart rate, keep it well controlled, can lead to improved symptoms. Antiarrhythmic agents, one of those 6 agents that I mentioned, may also significantly improve symptoms and decrease the recurrence of atrial fibrillation. For patients that remain symptomatic despite medical therapy, catheter ablation, that is atrial fibrillation, may have important roles overall. It's important to remember that anticoagulation for the appropriate patients is important for reducing the risk of stroke. Okay? So I'll encourage you to keep a list of questions that you want to ask on your pads. And with this, I will be turning this over to our panel, and we'll be asking them a variety of questions as well. Okay, so again, I hope that was informative as a good overview, but a lot of the fun is yet to happen, so we'll really enjoy this next part. Okay, great. So, you've heard, and I've introduced my panelists, so we'll talk, among ourselves and introducing you to these various topics. So I'll start with Dr. Park and maybe get her perspective on how she describes atrial fibrillation to her patients. What are the kinds of different symptoms to look out for? What's your general perspective when you first have this discussion?
Sure. So hi, I'm Shirley Park. Hello? Okay. So when I have the initial atrial fibrillation talk with my patients, the way I describe it, I don't know if Dr. Wang kind of touched on it, but so it's an electrical abnormality of the top chamber of the heart, not the bottom. That's what the atria are. And normally, the heart should activate in a very organized manner. And the normal activation results in an organized contraction of the top chamber of the heart. So atrial fibrillation is when you actually have very disorganized, chaotic, very rapid electrical activity in the top chamber of the heart. And mechanically, what that translates to is that instead of contracting, it just quivers or fibrillates. And that's where this term atrial fibrillation comes from. In terms of, and then what happens, as Dr. Wang says, there's a relay station or a staircase to the bottom chamber. So when your top chambers are going like this in AFib, it'll drive the bottom chambers very fast and irregular as well. So in terms of the symptoms, I would say the, more common or obvious symptoms that you can get are rapid heartbeats or palpitations. Some people get some shortness of breath and lightheadedness, sometimes chest pain. I have had patients that have had more subtle symptoms in AFib. So just a general fatigue or lack of exercise tolerance is the first thing they notice. They realize they can't, go up 3 flights of stairs anymore for some reason. I've even had some patients just have a personality change where I could tell immediately if they're in AFib when they come to see me in clinic because they're kind of a different person. That being said, there are some people that actually have no symptoms whatsoever in AFib, that actually it's just found incidentally on an EKG that they have for another reason. So there definitely are people that are asymptomatic, so no symptoms, and have no idea.
Great, that was wonderful. I'll ask Angela perhaps to talk about rate control. We talked about that as an important strategy. Can you say more about rate control and how do you know when you've adequately controlled the rate? What are your targets? What are your goals there?
Well, thank you everyone for coming, and especially on this rainy day. We'd love to have you here and hope you learned something from us today. The reason we like to rate control atrial fibrillation is because, for a couple of reasons. One, patients generally don't feel well when their heart is racing. And two, when the heart is racing, it can eventually lead to tiring of the lower chamber and cause a condition called tachycardia-induced cardiomyopathy. So these are the two primary reasons to rate control patients in atrial fibrillation. The goal generally is at rest, we'd like to have the heart rate between 60 and 80, and with moderate exercise, up to 110, 115 beats per minute. And the way we evaluate the rate control is we use special tools we have available to us, and those are monitoring devices. There are different kinds. The most commonly used device we have right now is a type of Holter monitor, which we are able to put on our patients for up to 2 weeks, up to 3 weeks sometimes. And that device gives us a general idea of how well the rate control is with a certain medication we're using, or what we're starting with before we start the rate control medication. So we prescribe these types of monitors regularly when we are starting the medication or when we're changing the dose or changing the medication to evaluate how successful we are in our treatment strategy.
Great, thank you so much. Dr. Park, maybe how do you could comment about how you decide when using antiarrhythmic agents are appropriate, that is when you want to control the rhythm, and how you go about selecting agents, particularly for the patient with a normal heart without structural abnormalities.
So the strategy of what we call rhythm control, trying to suppress the AFib, keep you in normal rhythm as much as possible. Primarily, the reason to do that is for symptom control. So, you know, if you're the type of patient that clearly knows when you're in AFib, does not like being in AFib, makes you miserable, obviously you want to, you know, go keep you in normal rhythm as much as possible. So that's the clear population. In terms of the medications, you know, Dr. Wang listed sort of 6 different medications. So focusing on people with what we call relatively normal hearts. So no evidence of heart disease, no history of heart attacks in the past or blockages in the arteries. And also people with normal pumping function, so no evidence of heart failure. In those patients, the 2 primary medications we use are called propafenone and flecainide. And those are the generic names. I'm just going to stick with the generic names for consistency. And so those medications I find to have the best ratio of effectiveness to least side effects in this population. And you can take them either chronically, so every day, to suppress your AFib, or for some people who have kind of very sporadic and fairly rare episodes, you can use a method called pill in pocket, where you don't necessarily take it every day when you don't have AFib, but if you have an episode of AFib, this is why it's called pill in pocket, you whip one out, you take a dose, and oftentimes it can help acutely convert you to normal rhythm. So it'll acutely terminate that episode once you have it.
Great, thank you. Angela, would you talk to us about when you're picking an antiarrhythmic agent for the patient who does have coronary artery disease, what are the different options, or for a patient who has decreased pumping function?
In patients who have abnormal heart function or who've had a heart attack in the past, we are using medications that are from class 3 antiarrhythmics, and those are Ticcasin or difetilide, sotalol, also known as beta pace, or amiodarone or jonadarone. The first 2, Ticcasin and sotalol, are initiated in the hospital generally and really depend on the kidney function. So we need to measure how well the kidney perfusing or clearing the medication in order to determine the dose. And in some patients, those medications may not be appropriate. There's, like I said, started in the hospital for the first 5 doses. And the reason for that is that both medications can affect one of the intervals that we measure on the electrocardiogram that can potentially be proarrhythmic or cause a more dangerous type of arrhythmia that is monitored for the first 5 doses while patients are in the hospital and on the monitor. Amiodarone is the other medication that we use a lot. Is one of the most effective medications we have available for atrial fibrillation, but also needs to be monitored carefully with some baseline liver function, thyroid function tests, some precautions that have to do with using sunscreen and so on and so forth. And these tests should be done every 6 months while the person is taking amiodarone.
Great, thank you. So frequently our patients come to us and ask us to describe the role of catheter ablation, when it's appropriate, when that would be a good choice for the patient. Dr. Park, would you like to speak about how you discuss that with patients, when you advise them to say, oh, we should talk about this today, this is something we should be discussing?
So in terms of catheter ablation, the first thing that I kind of make sure patients understand is that it's not a cure for AFib. So we don't have a cure currently for AFib. It is a chronic condition like diabetes and hypertension that you just have to manage and suppress as much as possible. So catheter ablation would fall into the rhythm control category. The rhythm control category, obviously trying to keep you in normal rhythm, includes medications, which we talked about, cardioversion, which is just the electrical conversion of the heart back to normal rhythm, and catheter ablation, ways to keep you in normal rhythm. In terms of when I have my initial discussion, I talk about all the options. Catheter ablation really, because the success rates are not in the 95% range, it's in the 60 to 80% range, as Dr. Wang mentioned. Generally, you have to have demonstrated failure of an antiarrhythmic medication. So either you can't tolerate it because of side effects, or you're breaking through maximum doses before I offer catheter ablation. So that's the initial sort of time point at which I more seriously discuss ablation therapy.
Great, thanks. So as I mentioned before, one of the things that we really try to do is to make sure we individualize therapy, that we find the therapy that's most appropriate for each person in their own condition, the degree, the stage of atrial fibrillation, whether it's been persistent for many years, the size and structure of the atrium, whether it's very enlarged, and we'll in fact then look at the different options. We'll also have the discussion in terms of what types of different therapies are available in terms of, as I've described, either freezing, radiofrequency, why we might choose one or the other in different circumstances, and also why we would choose hybrid therapy, the outside and the inside. Largely for patients who in fact have either had multiple failed atrial fibrillation ablations or in fact have the characteristics as I mentioned, very long-standing atrial fibrillation, persistent atrial fibrillation with large atria. Those might be patients that would be particularly suited for the hybrid outside and inside ablation approaches. So I'd like to turn to Dr. Beghi, one of our most senior cardiothoracic surgeons, and ask him for his perspective in terms of how he talks to patients about the hybrid approach.
Oh, thank you very much, Dr. Wang. Ladies and gentlemen, thanks for the invitation. I'm Ramin Beghi. I'm a cardiothoracic surgeon with training and expertise in cardiothoracic surgery, heart operation, heart-lung transplantation, and vascular surgery. So I work with Dr. Wang and Dr. Park and colleagues mainly for patients who have atrial fibrillation. In general, briefly, there are 2 or 3 different categories of the patients that Dr. Wang, Dr. Park, and colleagues may ask me to see and participate in their care. Sometimes patients, as it was mentioned before, they have structural heart abnormalities like problems with the valve or blood vessel abnormalities of the heart that are referred for heart surgery anyway. And these patients may have paroxysmal atrial fibrillation or persistent atrial fibrillation. So pretty much concomitant surgery, that if you're about to undergo heart surgery for something other than atrial fibrillation is indicated. For those patients, pretty much every one of them will be considered to also at the same time undergo this operation, which is called Cox-Maze 4 right now. Dr. Jimmy Cox was a surgeon in the 1980s at Washington University in St. Louis, designed this procedure. Back then, it would be cutting and sewing and basically constructing this maze in the back of the heart where the upper chambers are, so these abnormal rhythms don't find their way back to the lower chambers. Over the years, over the past 30 years, the operation has become a lot different and less invasive. It's still called Cox-Maze, but we use a different source of energy, usually radio frequency. We don't have to do a lot of cutting and sewing, and in general adds about maybe 20 to 25 minutes to the operation. So if you're undergoing surgery for your mitral valve, aortic valve, coronary artery disease, and you happen to have atrial fibrillation, then we can treat that. And then in general, we have success rates of, even for the people who have been persistently in atrial fibrillation for 10 years or so, approximately 80, 85 to sometimes 90% chance of converting them to normal sinus rhythm after the operation. There is this little appendage that sits on the back of the heart near the left atrium that appears to be the major source of clot formation for patients who have atrial fibrillation. So we either resect that appendage, remove it, repair it, or put a clip on it so that there is no propensity for clot to accumulate there, or at least reduces the propensity for clot. So that's one category, patients who have other disease. And the other ones are the ones that Dr. Wang and Dr. Park alluded to, that the patient has only atrial fibrillation, and for various reasons they are intolerant of atrial fibrillation, and then other conventional methods, medications and ablations and cardioversions, have not been successful. Sometimes patients don't tolerate warfarin. They may have bleeding from the gastrointestinal tract, or despite the fact that they're on warfarin, they may have symptoms of transient ischemic attacks or stroke. So for those patients, prior perhaps to about 2010, we would still take the patient to the operating room. Again, these are the patients who have no other heart disease except for atrial fibrillation. We will open the chest, put the patient on the heart-lung machine, and do the variation of what is called the Cox-Maze-4. And again, those patients would have about 80 to 90% chance of being successful. But then, since about 2010, we learned that we may not have to do a big open operation through the middle of the chest and put the patient on the heart-lung machine. We learned that through 3 or 4 port accesses from the right side and then 3 or 4 port accesses from the left side, we can cause lesions, or these energy sources can be used around the pulmonary veins, on the back of the heart. So minimally invasively, we can cause these sort of scar tissue in the back of the heart so the atrial fibrillation doesn't find its way down to the lower chamber. That by itself maybe have 60-65% chance of being successful. But if you combine that with what Dr. Wang and Dr. Park can do, which is take the patient back again to cardiac catheterization laboratory, again, relatively non-invasively, find other areas that still we may have missed through this minimally invasive approach, then we may approach 80-90% success that we did with the big open operation. So now, since about 2.5 years ago, we have had a number of patients that we have seen for this sort of we call it a VATS maze, basically, the relatively non-invasive approach to combine the two techniques of from the outside of the heart and the inside of the heart to convert the patients to normal sinus rhythm.
Great. Thank you, Dr. Beghi. We have Sophia Liu, who works with Dr. Beghi. Anything you want to add also, Sophia? Do you want to? Thanks.
Hi, my name is Sophia. I'm one of the nurse coordinator for cardiac surgery. So what we've done since 2010 is develop a process in managing our patients when they have the two combined procedures. So we discuss and have help patients from the time that they see us to the time they're discharged, how things are managed. We do a lot of teaching, support, and help them understand that, you know, they'll be in the hospital, stay for a couple days. Then for our first part with us with cardiac surgery, do the epicardial ablation. Then once they recover for a couple days, they go back with Dr. Wang or Dr. Park and do the endocardial ablation. And we help, our role is to help patient through the process, help manage and support and teach throughout their stay.
Great, thank you, Sophia. So we've talked a lot about catheter ablation and maybe what happens before a catheter ablation, but I'd like to ask Angela to talk about the specific considerations of anticoagulation after the catheter ablation procedure. What are some of the general principles of our treatment? Angela, would you like to talk about that?
Sure. The reason we anticoagulate patients or thin their blood essentially during and after the ablation procedure is because we are very concerned about one of the less common but very devastating complications of this particular procedure or atrial fibrillation in general, and it is stroke. So we take this very seriously. Generally, we anticoagulate patients with intravenous blood thinners during the procedure and overnight right after the procedure. And then we generally start them on oral anticoagulation agent the night after the procedure. Depending on what we use, if we use warfarin, we often now don't stop anticoagulation before the procedure as well. If we use one of the novel anticoagulant agents, we generally do stop them, and depending on the overall risk a particular patient has, we will bridge them with a medication called Lovenox, which is a medication that is given into the adipose or fat tissue, usually around the belly button and the abdomen. So we sometimes use that medication before and after the procedure as well. But if patients are on warfarin, we generally don't stop warfarin for the peri-procedural time. In terms of how long we keep patients on blood thinner after the procedure, at least 2 to 3 months after the procedure, and then we make a decision based on the overall risk. We currently use CHADS 2 score, CHADS VAS score that Dr. Wang mentioned, to determine that risk. If that risk is low or 0, we generally can stop the blood thinner at 3 months period. And if it's higher than that, we have a discussion with our patients about long-term use of blood thinner.
Great, thank you. So Dr. Park, do you want to pick up the discussion about selecting an anticoagulation agent? Maybe talk a little bit more about the risk scoring systems that you use and how you go about selecting the anticoagulation therapy.
So going back to Dr. Wang's slides on the CHADS-2 versus the newer CHADS-VAS risk scoring system, you know, the CHADS-2 score was the original system that probably most people use still nowadays. I think that I've sort of, in terms of when I decide to use one scoring system or the other, the CHADS-2, I think the reason they came out with the CHADS-VAS was that when you take the CHADS-2 alone, there's a lot of people that fall into this intermediate category of maybe 1 to 2 risk factors. And I think about 60% of the patients in the original study fell into the moderate category where you say, well, you can use aspirin or warfarin. So then it becomes more of a physician decision and a patient decision what you go by. So the CHADS-VAS scoring system, I think, was designed to try to delineate within that moderate risk population, who is truly low risk and who may actually be higher risk that you might be more inclined to use full blood thinners for. And so, for example, if you had a 68-year-old woman with a history of heart disease, a history of heart attacks in the past, you look at their CHADS-2 score, it actually is 0. And you say, oh, well, 0, that's low risk. You can use aspirin. And then you look at the CHADS-VAS score, which includes age above 65, not 75, heart disease, and being a woman. Now their CHADS-VAS score is 3, which actually pushes you to a higher stroke risk and probably, for me, would make me inclined to recommend full anticoagulation. So it's kind of, sometimes the CHADS-2 score and the CHADS-VAS score actually end up being the same. And one just corroborates the other, and that's fine. In terms of the, you wanted me to talk about the actual anticoagulants?
Sure.
Okay. So in terms of the anticoagulants, Dr. Wang touched upon what's available currently and what's FDA approved for AFib. So the sort of tried and true that's been around for a long time is warfarin or Coumadin. And then the 3 new agents, dabigatran, rivaroxaban, and apixaban. So the pros and cons of each are that, so warfarin, you do have to have your blood monitored at least about once a month, even if you're on a chronic dose. And a lot of people don't like getting their blood drawn that often. It is affected by the amount of vitamin K that you eat in your diet, because vitamin K can reverse the effects of warfarin and cause your warfarin levels to drop. And so it doesn't mean that you can't have anything with vitamin K. Those things tend to be the dark green leafy vegetables like broccoli and spinach, kale, things like that. It's just that you have to have a consistent amount every day. So if you're not able to have a consistent amount every day, it'll throw off your warfarin levels. The newer agents, the benefit is that you don't have to have blood monitoring. You just take them as any other pill. The downsides are that currently there are no reversal agents for these medications. So warfarin, for example, if you come in with some acute bleeding issue, you can reverse it acutely by giving vitamin K. The newer agents, if you were to have some major bleeding, you basically have to wait until it washes out of your system on its own. And I would say the newer agents also were not studied in a specific population, which is those patients with valve abnormalities, heart valve abnormalities. So either if you've had a valve replacement, or if you have an abnormal valve that's either leaky or tight, that population was not studied for the newer agents. And so you basically have to have no valve abnormalities in order to use the newer agents.
Great, thank you. So one of the things that we mentioned earlier was the ability to convert someone from atrial fibrillation back to normal rhythm. And we said that could be done with medications or with an electrical shock. Now, there are particular certain steps that we need to take in terms of anticoagulation prior to that. So I'd like Angela to maybe talk about that. How do we get patients ready for a cardioversion, that is that conversion to normal rhythm, in terms of anticoagulation?
First of all, let me tell you what that procedure is very quickly. This procedure is done under anesthesia, so patients don't remember and don't know what is being done to them. They're completely asleep. And we put pads on their chest and the back, and after they're completely asleep, we deliver a shock which resets the heart basically back to normal rhythm. So one of the risk factors of this procedure is when we reset the heart back to normal rhythm, it starts squeezing well again, and if there is a blood clot in the atrium, it can squeeze it and send it into the brain or to the lung or into the heart arteries. So we take anticoagulation again very seriously to prevent these particular complications. So the rules are, if the patient is in atrial fibrillation for over 48 hours, or if the duration of atrial fibrillation is not known, we generally need to do one of two things. Either have them effectively anticoagulated for at least 4 weeks before the procedure, or do a procedure called transesophageal echocardiogram. Basically, it's an ultrasound of the heart that is done with a special probe, again, after the person is anesthetized. The probe is placed into the esophagus or food pipe, and the camera at the end of the probe has the ability to look inside the left atrium, which is where the clots mostly form. So if we need to do this procedure, it's done concomitantly with the cardioversion. So we do the TEE or transesophageal echocardiogram first. We confirm there is no blood clot, and then we can proceed with the cardioversion. Again, either we anticoagulate a person for 1 month, 4 weeks, or we offer a TEE or transesophageal echocardiogram. And then we must continue anticoagulation for at least a month after the cardioversion procedure, regardless of their CHADS-2 or CHADS-VASc score.
Great, thank you so much. So one of the things that we in our service really pride ourselves on is really staying at the forefront of really all the developments, particularly in the care of atrial fibrillation. And so we've been involved in the clinical trials, as you mentioned, in terms of the approvals of many of these new technologies, cryoablation, laser ablation, et cetera, as well as the hybrid surgical procedure. And really at the forefront of that is Linda Norton, who's our research manager. So patients often ask, well, why should I participate in a clinical trial? Are there any particular advantages to me? So I'd like her to offer her perspective about being a participant in a clinical trial.
So I'm delighted to see you all here today. And of course, part of the package of things that we offer people is not just very expert care and a very elaborate care program for our patients that we collaborate with, but in addition, we want to offer people cutting-edge, novel, new kinds of care. We're in a perfect area to do that because we're in Silicon Valley. So we have a lot of techie people who want to hear the latest and the greatest. We have a pretty established clinical trial program. All of our clinical trials are listed on clinicaltrials.gov on the Stanford clinical trial website. Those of you who came in may have seen a pamphlet, which will always be in our clinic, telling you about all the trials that we currently have and those that are about to happen. And in AFib, you can imagine, because of the number of people who have AFib, we have quite a few clinical trials related to atrial fibrillation. We've participated in a lot of cutting-edge trials, and Dr. Wang in his slides spoke about cryoablation. We were in the first 2 trials for that and are now using it as a standard practice for patients who have pretty much paroxysmal AFib. We also were involved in smart touch and laser approaches to AFib. Those patients are in follow-up currently, and those 2 technical pieces of devices that we use during treatment for ablation will be marketed pretty soon, but are not yet. The FDA kind of wants to look at all of that data from all the sites that participate and then decide when they can be marketed and used around the United States. We're also involved, and Dr. Beghi spoke about this, so did Sophia, and so did Dr. Wang, the study for persistent AFib, which is that hybrid approach. So we've participated in 2 trials. There will be a 3rd one coming up, and our patients are in follow-up for that study. What's unique and wonderful about that is people who are in AFib all the time, persistent AFib, now have an option which did not exist before of having a more successful procedure. It's more elaborate and more involved, but the patients that we're following in that trial have been very satisfied and really pleased that they went through it. So you can imagine that in part of this collaboration that goes on with all of us is we look at how you might be treated, and then we'll offer you another option to be in a clinical trial. Trials have inclusion and exclusion criteria. So that means all of you cannot be in a trial. What's very important is that the population get defined. Who are they? They have to be very narrow. They have to meet certain criteria. So that's sort of where I come in. I'll look at who we're looking for and whether you meet the criteria or not, and then I will confer with my colleagues and say, this person might fit this clinical trial. And either it's when you come here to see us or when you're in clinic, we'll have that discussion to offer that option. And that comparative effectiveness trial that Dr. Wang spoke about, CABANA, is really a trial that's looking at medication versus ablation in any kind of AFib patient, whether it be paroxysmal or persistent AFib. That trial is now enrolled 1,700 patients internationally. We think it will end enrollment at the end of this year, at the end of 2014, and we will learn more about the management of AFib than we have in any other trial. So it is a landmark trial. We do have quite a few patients in that study, but we need to get you a little earlier on in your treatment for you to fit that CABANA trial. We have another clinical trial coming up, which is the one that Dr. Wang showed the picture of as well, and that's the one called ENMARK, and that will be starting in April. Obviously, all of our trials are not just AFib trials, but we have such a large population that we like to look at AFib trials for sure. When we select trials, it has to be because we think it would benefit our patient population. That's sort of a number 1 criteria. Why would you be involved in offering a study? We want to also offer novel and new treatments to people that they cannot get elsewhere. So to receive that hybrid ablation, you really need to be in a clinical trial to make sure that it is an opportunity that you can have. Why would it be beneficial for you to be in a study if you fit the criteria? Probably the biggest reason is because you get the offer of being involved in something that's cutting edge that you might not get anyplace else. you get followed very intensively. So you have another pair of eyes that's looking at you and following you through the course of your treatment. And we usually follow many variables along the way. So your EKG monitoring would be substantial. And then you provide also information to advance the science. So what happens for some of our very altruistic patients is they say, I want to make sure you get the most information so that you can kind of advance care within EP. And I think I've kind of hit on what I wanted to talk about in terms of our studies, and look forward to you calling me in the future if you're interested, and coming to visit us and hear about what we're doing. Thank you.
Thank you, Linda. The last thing I wanted to say on Linda's behalf is that I remember a patient recently, and we'd finished, I think, a several-year follow-up, and so the patient's remark to me was, "You mean I don't get to see Linda anymore?" So she was really sad that she didn't get to see Linda. So you get part of a kind of a family. You get a new adopted family for a while you're in a clinical trial. So I'm going to ask our helpers to collect, and I hope you've written down your questions, and we'd like to get to as many as possible. And so if you do, just kind of pass them to the middle if you wouldn't mind, and we'll go ahead and collect them as best we can, and we'll get to them. Great. Okay. We can go and take a few of these too, so I'll speed these things up. Okay, so I'll take one here. So can yoga help in controlling AFib? So probably so. I mean, obviously the trials are often limited, studies are often new, but there is some data to actually show that it can. And so I think it's part of a general idea that reducing stress may in fact be important. Okay, so I will answer that one because it's so quick. Let's see. Prevention methods: diet, exercise, sleep, medication, stress. Do you want to have any other comments about that, Dr. Park? I don't know.
So basically preventing AFib from being triggered, preventing AFib episodes. Clearly, if you have a specific trigger that you know is always associated with AFib, avoid it, whether it's caffeine or stress or alcohol or whatnot. There is some evidence that there is a link to obesity and AFib. So weight reduction in general, just for general fitness, we always encourage. There is an association with sleep apnea and AFib as well. And a lot of people actually go around undiagnosed with sleep apnea. And if you treat the sleep apnea, the arrhythmias actually do get much better. So that's another big thing that we look at for preventing AFib.
Okay. Angela?
The question is, how do beta blockers affect atrial fibrillation, and what do they do? Beta blockers are agents that affect the rate, so we use them for rate control. The examples are atenolol, metoprolol, propranolol, or in some instances we use Coreg in patients, especially with heart failure. So these agents are supposed to reduce the number of beats that are produced by the lower chamber in response to the atrial fibrillation.
Okay, great. So I'll take a couple of these quickly. Yeah, thank you. So what's the difference between atrial fibrillation, atrial flutter, AFib, and SVT, and particularly about atrial flutter? Okay, so great questions. So atrial flutter, first of all, is typically a very uniform circuit. So the signals go round and around in a very specific pattern, unlike what I showed for atrial fibrillation, where it swirls around. And so they have some similarities, which I'll mention in a moment, but they're in fact different rhythms. What about atrial flutter in particular? Are the same medications used? Really, yes. Is ablation an option? Yes. It's actually a simpler procedure for most people, a much more successful, 90%, et cetera. And so it's another good choice. As far as SVT goes, SVT has several different forms, but it typically comes from one location in the heart. And it's a little kind of flashing light that kind of goes around and around and causes a fast rhythm, which will need to be diagnosed by a monitor. Angela, do you have one there?
What follow-up testing needed for Tickerson? Like I mentioned before, Tickerson is one of the antiarrhythmics we use in patients with heart failure or coronary artery disease. This medication requires admission to the hospital for the first 5 doses because it can affect one of the intervals on the electrocardiogram that we monitor. So that would be the follow-up test that would need to be done. Probably at each visit you come to see your cardiologist or whoever prescribed this medication. And also the renal function test, because creatinine clearance or renal clearance really affects the level of the medication in the bloodstream. Also, this medication level is often affected by a different antibiotics or other medications. So if and when you're started on any medication, if you're also taking tickesin or difetilide, it's a good idea to check with the pharmacist or with the cardiologist whether you can take a combination of those two.
Okay, great. I'll take a few of these quickly. Is AFib more likely flying on a plane? So I indeed think it's pretty stressful. So there's a lot of problems of potentially sleep deprivation, dehydration. There may be an altitude issue as well, and some people talk about going to altitude, Tahoe, et cetera. So it can be a stressor. Do premature beats often progress into atrial fibrillation? They can, but they usually do not. Most people just have premature beats and they don't progress into atrial fibrillation. A third I'll take quickly is, what are the long-term side effects of amiodarone, say 200 milligrams a day? So side effects with amiodarone are generally cumulative over time. The longer the time, the higher the strength, lowest at 200 milligrams a day. The most serious things are lung and liver, and we do tests, breathing tests for the lung and blood tests for the liver. It can affect the thyroid as another one. Dr. Park, do you want to take your questions?
Sure. I have 2 sort of related questions. One is go over the part about effectiveness / sequelae of ablation, and then what do you mean if you say success? I mentioned a 60 to 80% success rate for catheter ablation. Officially, in terms of where those numbers came from, the trials, success was defined as no recurrence at all of AFib for up to, on average, it was about a year post-ablation follow-up. So that's what success technically means, I guess. That being said, I would say probably a greater percentage of people, even if you're not completely successful in that you're AFib-free for a year, do still get a dramatic reduction in the amount of AFib that they have. So for example, if you were persistent beforehand, now you may be paroxysmal. Or if you had episodes every week previously, now you may have episodes only twice a year, that kind of thing. So that percentage of just reduction in AFib burden is quite a bit higher. In terms of the sequelae of ablation, and I'm talking about the standard ablation with either radiofrequency or the freezing balloon. So clearly, things like infection and bleeding, general risks for any procedure. AFib in particular, there's a risk of damaging anything that's close to where you're ablating. So that can include things that are close to the left atrium, where we do our ablation, are the esophagus. That's probably, it's very rare, but probably one of the more devastating potential complications, where you may injure the esophagus as you're burning in that area and create a little what we call fistula, or a little connection that forms over a couple of weeks after the procedure between the heart and the esophagus. I don't know, we haven't really seen that at Stanford. I think we've come up with ways of avoiding esophageal injury, primarily by putting a temperature probe in the esophagus during the procedure. And so if you're coming close to the esophagus with your heating catheter, you'll see the temperature rise in the esophagus. You know that you're in that vicinity and you just move away. And I think that's minimized a lot of that particular side effect. The other structures that are close to the heart where you're ablating are the pulmonary veins, which is actually the target of ablation. Now, we don't actually burn inside those veins. We try to stay in the heart, just around the entrance sites of those veins. But there's a possibility if you get too close and you burn too close to the veins, that the vein entrance sites may get tight, get stenotic. And then lastly, the nerve that innervates the diaphragm on the right side also runs right behind the heart. And there's a potential for injuring that nerve and getting paralysis on the right diaphragm. And those are probably the AFib ablation specific complications.
Great. So I'll take a few of these quickly. One is how to avoid it. So we know high blood pressure, diabetes control is likely to be influencing it, as well as sleep apnea treatment. So those are some of the things. Obviously, there are many different considerations that are individual. One question is, does atrial fibrillation flutter cause atrial hypertrophy? Would that be a problem? So one thing we do know is that when atrial fibrillation continues, it causes some degree of enlargement likely of the atria, which makes it harder to get out in the future. By itself, we're not certain whether it has a big impact on overall survival, et cetera, but it does perpetuate itself. What happens to an AFib patient when he does absolutely nothing? And so it really relates to that similar kind of question, whether someone will develop symptoms in the future. Difficult to know, but as has been discussed, many people are truly asymptomatic, so the focus is generally on stroke prevention. Another quick one is, I was diagnosed with atrial fibrillation, flutter, and arrhythmia. What's the percentage success rate? Again, we talked about the success for atrial fibrillation. The success for atrial flutter is, again, much higher. And lastly, another quick one, is it curable? Why not? So as Dr. Park mentioned, generally there's a recurrence rate that's possible. There is, however, probably some small subgroup that probably will never have this again. We don't know exactly how to find those people, but they seem to potentially exist. There's some incidence of atrial fibrillation occurring even though, in fact, they've been, quote, free of atrial fibrillation for maybe even 3 to 5 years. It can come back even after that. And Angela, do you have a couple there?
What is syncope? Syncope is a sudden loss of consciousness. It can be related to a variety of things, but speaking of atrial fibrillation, usually it can be related to a sudden cease of atrial fibrillation and return to sinus rhythm or normal rhythm. There may be a pause between the normal beat and the last atrial fibrillation beat, and that pause, if long enough, can cause a person to feel dizzy, lightheaded, or lose consciousness completely.
Okay, great. So let me just take a few of these. Do people with paroxysmal symptoms usually get worse? So in my experience, the way I describe the patients, it's pretty variable. I'd say most commonly it's fairly stable. It just goes up and down. There are periods of a lot of AFib, a little AFib, and it keeps undulating up and down. There is some subset of patients who the atrial fibrillation gets much worse and it goes to persistent. But in general, they can go years as paroxysmal, in my personal opinion. Ablation procedures hindered or affected by pacemaker. I have bradycardia and have been recommended for a pacemaker. So the pacemaker is designed to keep the rhythm from going too slow. Many patients with atrial fibrillation do have such a condition. So they may need treatment for atrial fibrillation and a pacemaker. They may not substitute for one or the other.
Okay, so talking about persistent AFib, generally feeling okay, had a cardioversion, normal rate for 3 days afterwards, have not taken rate-controlled drugs because of the AFFIRM study, concern about side effects of the drugs, taking warfarin. Do I have to take a rate-controlled drug? I'm not, I guess rate control, if you're back in atrial fibrillation, it depends if what your overall heart rates are like. So that's why we do what Angela mentioned in terms of getting monitors, long-term monitors as an outpatient to see what your overall your heart rates are doing when you're in AFib. If they're actually within an acceptable range, you don't necessarily have to take a rate control agent. Some people kind of rate control themselves in a way, just the way their conduction system works. You know, I have to say it depends on what your heart is doing in AFib.
Okay. Dr. Beghi, you have a question?
I have a question that what percentage of patients subsequently redevelop atrial fibrillation post-surgery? And the question is it 19%? Well, for the patients who have paroxysmal atrial fibrillation and they are undergoing concomitant cardiac surgery and then they have surgery for paroxysmal atrial fibrillation, the developing atrial fibrillation rate subsequently is very, very low, perhaps 2 or 3% for those patients. The patients who have had been persistent long-term atrial fibrillation, for 2 to 3 months after surgery, they may have episodes of atrial fibrillation, but approximately 80 to 90% of them after 3 months would be continuously in normal sinus rhythm. So the answer is probably somewhere between 10 to 12%, 10 to 15% that may develop it again.
Angela, do you have one?
What is the difference between paroxysmal and persistent atrial fibrillation? Generally, paroxysmal atrial fibrillation kind of comes and goes on its own. It doesn't need to be, we don't need to do any interventions to stop atrial fibrillation in those who have paroxysmal. In persistent, we generally need to do something, either administer medications or cardioversion or do an ablation procedure to terminate it. And another question, a very good question. What is the sequence of treatment options? Rhythm control, stroke prevention, and 3, I presume, rate control. So these 3 are determined depending on symptoms and risk of stroke in the particular patient. So we determine the treatment option for each individual patient based on what else is going on. It's not uncommon for patients to be on rate control, rhythm control, and take a medication for stroke prevention.
Okay. Dr. Park?
So I have a question, which is probably what we're trying to answer. So why do you have to take antiarrhythmic drugs before and fail them before you consider ablation? Is it not better to do ablation as soon as possible? That's a very good question. Currently, per our practice guidelines, guidelines say you have to have tried the antiarrhythmic medication first. I think guidelines are basically expert consensus on what's best for the patient, risk versus benefit for any therapy. If you have some studies and data that backs up those guidelines, they're also used. And that's, I think, the issue right now is we don't really have good data per se on ablation versus antiarrhythmic therapy. That's what the Cabana trial is trying to look at. I would say, because the ablation success rate so far, the most in terms of success we've demonstrated is 80 to 85%. It's not like the flutter ablation that Dr. Wang alluded to before, where it's a discrete circuit. The ablation can be curative for that flutter circuit. If you basically break the circuit, it will not come back again. So for flutter, it actually is in the guidelines to offer ablation up front as first-line treatment before trying antiarrhythmic medication. For AFib, not quite yet.
Okay, I'll take a few of these. What's been done for prevention? Why is AFib increasing? Is it because of the number of elderly patients? And I'll take that. So yes, we think that the fact that the age population is going to the right and people are living longer, et cetera, is a major factor, as well as the presence of hypertension, diabetes, metabolic syndrome. Is it common for AFib to convert spontaneous to sinus rhythm? Yes. Does spontaneously converted AFib often reconvert to AFib? Potentially, yes. For how many years is ablation effective? That is, as I mentioned, it can be totally effective, it seems, and then maybe about 5% per year seems to come back. What foods are antiarrhythmic? Hard to say. I would say. Do we distinguish between AF and more benign early beats? Yes. So an ECG can distinguish those pretty clearly. Does anthracycline therapy cause AFib? It can cause cardiomyopathy, it can lead to atrial fibrillation. What about warfarin during endoscopy? Most GI specialists require you to stop it or go on to a transitional medicine like the injectable heparin. Can you comment about metoprolol drug dose, once a day, twice a day, et cetera? There's a long-acting version of metoprolol, which can be taken once a day, and there's a short-acting, which needs to be taken twice a day. Would this reduce blood pressure? Yes. I think this is supposed to be the Watchman device, which is a device that is in FDA regulatory now to try to occlude the atrial appendage using a device you put in, which may be equivalent to warfarin. Coenzyme Q10, not certain what its value for atrial fibrillation is. And Linda has one.
So I have some astute observer who are asking study design questions. Do you offer the most successful treatment to patients in the control group? Of course not. That's a terrible design. So what happens with study design is you really are randomizing, and that's your best design. It's saying, here's your standard of care treatment, and sometimes you compare that to your intervention, but you randomize people before they're selected to compare those two groups. So that's a well-designed study. And then it says, can patients in studies receive treatments they need in addition to study medications or surgery? It's part of why you go through inclusion and exclusion criteria. If you feel like there's something that will really interfere with your primary research question and your study results, those people are excluded from the study. If they should, somewhere along the way, need something that is over and above beyond what your treatment question is, then there are all kinds of options. Either there's a subgroup that gets analyzed separately within the study, or people can always be removed either by themselves or by the PI that's on the study because they need something in addition to what that primary research question is. I mean, remember, patient safety and treatment comes first in terms of research. It shouldn't be any other way.
Okay, Dr. Park.
Does a dose of aspirin matter in stroke prevention? So that's a very good question. So a baby aspirin, 81 milligrams versus a full dose, 325 milligrams, that has been looked at in a number of studies. Unfortunately, there were equivocal results. Some showed that there was benefit with the higher dose, some did not. And so currently, I go by whether you can tolerate the 325. A lot of people have GI side effects or other bleeding, like nose bleeding or things that get in the way. In which case, I don't feel strongly about pushing for the higher dose per se, and I'll be okay with the 81 baby aspirin.
Okay. All right, so do diet, exercise, sleep, medication, stress reduction prevent atrial fibrillation? So probably, again, we have the best data for stress reduction, but we do think probably certainly sleep helps that. As far as diet and exercise, probably so. Is a referral needed? So again, just you can contact us, and there's some numbers to contact. A smartphone monitoring. So I have a number of patients who bring in recordings of smartphone. They're pretty good. They're not perfect, but they're pretty good. Does a pacemaker help? So really only insofar it allows your doctor to give you medicine that otherwise they couldn't because it would slow the heart rate too much. You mentioned beats over 500 beats per minute. Is it considered AFib if it's lower? Not clear if atrial flutter is less serious than AFib. It's hard to count how many beats there are when they get to be so fast in the atrium, so it's hard to say. Is atrial flutter less serious? They both cause stroke. Maybe a slightly lower in atrial flutter overall. Let's see. Do you have one, Shirley?
Yeah, I have a couple.
Yeah, go ahead.
So AFib, sleep apnea, TIA, are these interrelated? They can be. We do know that sleep apnea is definitely a risk factor for AFib. It's also a risk factor for high blood pressure and stroke. So yes, definitely. The second one is it necessary to switch from amiodarone to dronedarone even though no obvious side effects, such as lung fibrosis or thyroid problems from the amiodarone? So the amiodarone toxicities are generally related to the iodine that's in the amiodarone and iodine overload. And I know, at least for the thyroid in particular, which is very susceptible to iodine, even if you actually stop the amiodarone, the iodine still hangs around in your body. You can actually see thyroid problems up to 1 to 2 years after you stop the amiodarone. So, I would say, that's why we monitor your blood tests every 6 months, and even if you don't have any signs of it currently, it still potentially has some longer-term effects. So, That being said, dronedarone, it does have, so far, fewer side effects, organ toxicities than amiodarone. In the study that got it approved, it appeared to be just as effective as amiodarone. I think anecdotally, I've been finding that it actually has not really been that great and antiarrhythmic. So I think we're still looking for that perfect drug that has very effective and has few side effects. There's a second part. Would you suggest patient to do cardioversion if paroxysmal becoming persistent? I would probably say, I would say yes, because clearly if your AFib is progressing, you want to try to suppress it early on before it becomes truly persistent or permanent in some folks.
Okay, I'll take a few of these quickly. Does Medicare insurance cover these? Generally, there's accepted procedures, most of these. Given the mass number of nerves that can be ablated, how do you find the ones? So they're not nerves, they're parts of the cells that are part of the heart, and there are a variety of ways that we can do that, some of which are mainly anatomic, based on the triggers such as the pulmonary veins. As a person ages, the risk of falling increases. What would our comments be? And that's the risk-benefit as we try to figure out whether patients should be on anticoagulation. The majority of people who don't fall regularly, even though they're at risk of falling, generally are still felt to be candidates for anticoagulation. AFib, 2 to 5 minutes, 2 times a month, weakness and lightheadedness should be addressed. Probably, if you feel you have symptoms like weakness or lightheadedness. Does chronic persistent AFib cause a decrease in lung functionality? That's a complex question. Hard to know. That's a complex question. Okay, that's fine. If you can consistently control PT with normal range, is Coumadin equally good or better medicine than those other ones? Very controversial, because it's felt that when they've done subgroup analysis on people who actually have very well controlled, it's not clear that the other anticoagulants are any better, et cetera. What LDL should you have to prevent AFib? The relationship is tough to establish, so we don't have the guidance on that. I'm 59. Does AFib, will it become a higher risk when you have greater than 65? What should I do then? So we do know that as you age, your risk of stroke goes up. Beyond that, we're less clear as what happens in terms of the overall mortality, et cetera. Sleep apnea, we talked about, is important. Let's see, effective stress, we said yes. And the clinicaltrials.gov is probably the one. There are some listed on the Stanford trial site as well. What treatment you would recommend for a patient with persistent AFib without symptoms? So again, stroke prevention is the most. Other than that, we have to look at heart function and things like that to assess. How do you know if you have cardiovascular disease? That's a tough one. Hard to sometimes know how to diagnose that when it's not known. But I think the biggest thing is to look for symptoms. Things like shortness of breath, unexplained fatigue. My mother's occurrences are increasing from 30 to 60 to 70, I think. And does this mean her medicine is not as effective? It's time to change? Potentially, if it seems like previous medications aren't working now. And Angela has one.
I have a couple.
Okay.
What are the expected hospital stay for different procedures? Cardioversion procedure does not require overnight stay. We generally allow patients to go home within a couple of hours. A catheter ablation procedure generally requires overnight stay. We just monitor you, make sure that everything is okay, you're not bleeding, and then send patients home the next day. Hybrid procedure requires a longer stay because it's essentially 2 procedures, and we wait a little bit in between. So that's about 5 days to a week hospital stay. And the other question is, why would the doctor want to wait for my heart to reset versus to have an electrical shock? It's a very good question. And it has to do with how symptomatic a person is and the ability to do the procedure within a short period of time. It's also a decision is made based on the anticoagulation. So it's a complex decision that is made between the physician and a patient.
Okay, I'll do the last few. Flecainide, how long can you take it? As far as we know, for decades. For heart rate, which is better, beta blocker, calcium channel blockers, they're both pretty effective. or in combo. You can take them in combo. If paroxysmal becomes persistent, will all the rate drugs need to be used? Not necessarily, just whatever is needed to control the rate. Are there any first-line drugs versus second-line? Yes. So for the people with normal hearts, probably the flecainide or propafenone, and as Dr. Park mentioned, some other one, based on whether you have heart disease or not. So I first want to, say thank you to our wonderful panel for being here. The wonderful people from Stanford who put this together and supported us here, and all of you for your attention, all of your wonderful, wonderful questions, and thank you for the privilege of speaking to you. Thank you very much.